I said, well, one thing I think happens is that maybe the topics you had in the last, maybe the last two tests anyway, or three, are still pretty fresh in your memory. The things that are the least fresh in the memory are those things from the very beginning. And those are also subjects that tend not to hold your interest as much. Um, the critical thinking, the teaching and learning, the legal ethical, some of those that we started off with, before you get into more of the nuts and bolts, I think it's easier to discard that. It's a little more along the lines of memorization, some of it. So I tell students to try to study those sections a little bit. You have to look at your boyfriend and decide where your weaknesses are when you think back to the test you did well on and not so well, but also how much do you really remember about the other things. So, okay, I made a few notes on critical thinking. I said that you should go over the attitudes that foster critical thinking. And also, let me find my page numbers. There were a few page numbers. There were only about 4 or 5 page numbers in that chapter that seemed that had almost all of the information, and it was the first. Let me find this here. 144. Okay. There on page 144, which is the first page of the chapter, it talks about the 10 effective components of critical thinking and then the 7 skills. So I would review those because I think they're the sort of things that none of us, including myself, would tend to remember. But, and so that's on page 144. And then, let's see, I had a couple more. Okay, those attitudes that foster critical thinking are on page 148. They start on page 148. They're big font, blue. Those are things that it would probably pay to go back over and give a little bit of consideration to. And I'd probably read at least the chapter highlights just to think, okay, like I said, this is like, what, 5 pages? It's a very small chapter. But there was a study by Benner, I'm looking for it, that talked about that, okay, that was, I think maybe, they took people they took nurses and the international experts, supposedly from 9 different countries, to try to pull together those affective components and cognitive components of critical thinking. So, you don't need to know 9 countries and that sort of thing, but those were considered important. Let me see if I put anything else in that I thought you would want to spend a little time on. I would just say go through your slides a little bit. There shouldn't be a great deal of material to review there. And then in legal and ethical, I made a couple of notes on that as well. Chapter 4 and 5. Let's see, the code of ethics. I would definitely want to review that. Witnessing consents. It seems really simple, but it's really not. It's not as black and white, I guess, as it could be, because who is responsible for educating that client about what the pros and cons of the procedure is going to be? The doctor, right? So what is the nurse's role in relation to that education? Making sure they understand it. So basically, yeah, it's kind of like clarification, but be careful there. So you would probably just say something as simple as, did Dr. So-and-so, or did the PA, someone who's gonna do a thoracentesis and make a licensed independent practitioner, whoever's gonna do the procedure. Did so-and-so come by and talk to you about, what they're wanting to have done? And if they say yeah, then okay, that's good. Then they got their education. Do you feel like you understand everything, or do you have further questions? So if they start asking you questions, that's where it gets a little gray, because really, as a nurse, you should not get involved. We do a lot of patient teaching, but we really should not do the practitioner's job there, because if you say something that differs a little bit from what they said, or it's understood a little differently, then it can be turned around so that you kind of wandered outside your scope of practice a little bit and gone into theirs. So the way I handle that is if they, I might say, well then, are you comfortable that you know the pros and cons enough, you're comfortable enough to go ahead and sign your consent? Or if you're not, we'll have Dr. XYZ come back in and talk to you again. And never hesitate to do that, because that's their job. And part of what you do as a nurse is advocate for a client. So that's one time when you really don't do the patient teaching, is on a procedure. Even though you feel like you know it really well, that's not for you to do. Okay, so what if the family member is being impatient and mom's got a little tremble in her hand, and family member says here, and kind of guides their hand and is helping them sign the paper? Is that okay? Mm-hmm. What do you think, Joshua? Okay. What do you think? No? No. The Enid's shaking their head no as well. And what I'd say to that family member, and I'd probably go get another consent and start over, is we like shaky signatures. We don't care how shaky they are. Doesn't bother us at all, but he needs to do this for himself. As long as someone else isn't their power of attorney or something, then we need to go ahead and let them do it for themselves. So, you just nicely tell them that we can't, because that's kind of like coercion. That's wandering into the area of coercion, and you cannot have coercion. We can't say, come on, Mom, you need this procedure here, let me help you, your hand's shaking, and help them sign it. We just can't do that. As family members and as nurses, then we have to interfere. Nicely, but we have to interfere. Okay, so they have to sign it without coercion. You have to feel like they have gotten their education. What about their competence? Whose job is it to say whether they're competent or not? This is another murky one. Stillwater.
A judge?
Okay. Sometimes there is a hearing to decide whether someone's competent. Basically, we as nurses, we don't decide who's competent and who's not for legal reasons. However, we have a little bit of, if someone is clearly not understanding, that maybe they're in that stage of dementia where they agree to everything. Did Dr. So-and-so come to you? Oh yeah, he's a great guy, I really like that guy. Do you understand? Oh, well, sure, I understand. Hey, if I told you this joke, and then they wander off on something else, and are you comfortable with science? Oh, yes. Basically, they've said yes to everything. But then, something tells you that they don't have a clue what they're agreeing to. Maybe every time you've seen this person in the last 24 hours, they've said yes to everything, even when they didn't mean it. Then it's your job to say, I'm not really comfortable that he understands this, like, you know, and then I would go to my partners and say, I'm not comfortable witnessing this. I'm not convinced this person knows what they're signing. And then I just hand it off and it's someone else's problem. No, we're not saying they're competent or they're not, we're just saying we're not comfortable that they are. So, if I gave someone morphine an hour ago and they're just snoring away, and the doctor says, go get this signed, I've got a cancellation in my surgery schedule and I want to get it done. So move. I'm gonna have to say, you know, I can't right now because he's too sick, or he's not snoring away, he's happy and laughing and having a grand old time. But I know he's too much under the influence of medication to be clear to sign the consent. And I'm going to have to tell that practitioner, gosh, you know, I'm sorry, but the timing is really bad right now. We're going to have to let this wear off for a little while before we do that. And then if they give you any guff, then again, call your supervisor and let them deal with it. But you know, you can, and your supervisor might go ahead and have them sign it, but that's not your nursing license, right? That's somebody else's. So if you have concerns, basically don't do it. Don't witness. But you're not the one determining if they're competent. You're not the one providing their education. You are watching to see that they're not coerced, because as an advocate for the patient, that is clearly within your role. And on the others, if you can see that this person is heavily medicated, or that they really do not understand what they're saying, what's going on, despite everyone else saying they do, then you just gracefully step back and let someone else take the heat for that. Does that make sense?
Yes.
Okay. I hope so. And yeah, I hope I didn't confuse you. If I did, email me or put it on discussion board. But it's not different than what it says in the book. It's just a little more information on it. Okay. That's probably, were those my first two lectures were critical thinking and legal and ethical. So I think Ms. Haig may have been next.
Yep, I think I'm next. We'll do them in order. Nursing process is the next lecture. As far as notes, okay, so I'll give you guys some notes. You know, keep in mind, you know, you're responsible for what's in your textbook and what's in your slides, but I'll give you a few notes to kind of guide you as you're studying. Be sure that you understand the phases of the nursing process, what happens in each phase. When do we make goals and outcomes? Planning, right. And also what I want you to look at too is how do we evaluate goals and outcomes? Like, what do they need to be? We talked about specific things that needed to, when you're writing a goal, what are you looking for? How do you write a goal or an outcome? So those kinds of things too. That's about all the notes I have on nursing process. The next one for me is teaching and learning. The notes I have down for that include knowing the factors that we talked about that affect learning and how to evaluate teaching. I have a couple of just overall notes that kind of across different lectures, and that's kind of go back and look at your concepts for prioritizing and for delegation, because remember those questions can kind of cross over into other topics. So you'll pick questions that are about that in a variety of topics. So, you know, delegation and priorities. So if, you know, how sometimes you'll see those questions that are like, you know, who would I see first? What can I delegate? So be sure that you remember those concepts that you use to make those decisions. I think the next one's mine too. Communication. Remember, we talked a lot about verbal and nonverbal, so take a look at those. What makes up verbal communication? What makes up nonverbal communication? Another thing we talked about a lot in that lecture is helping relationships. What are the phases of those? What happens in those? What's the purpose of those? I'll wait a second because we're writing here. Okay. Purpose of those, yeah, that relationship and the phases in that relationship. At different points in this lecture and other lectures, we talked about interventions for communication difficulties. You know, how do we handle people who can't see as well or hear as well? That sort of concept. So how do we assess for those things, and how do we change our behavior when we see those things? And then the other thing that's big in that lecture is the therapeutic communication techniques, those things that improve communication, those techniques that do not improve communication and can be barriers to communication, so be familiar with those. And there is specifically some page numbers for you. There's that big table in your book that we used when we did that activity that's between like page 420 to 422. So look back at that table. What's next? Is it still me? Legal and ethical, oh, yep, it is. Growth and development. So growth and development, be sure that you're familiar with the physiological changes that happen in each of those age groups. Remember, we kind of broke that down to young adult, middle adult, and then we moved on into older adult with it's like a lecture of its own. So for all those groups, physiological changes. For the older adults, physiological changes of aging. We talked about a lot of those. Be familiar with those. Also, developmental tasks for each age group. Yes.
They're asking you to slow down just
okay. I can do that. I was trying to watch here, but I wasn't doing a very good job of watching when we're still running. So overall, the three broad categories are in each group. Know what are the physiological changes, what kind of developmental psychosocial tasks. And then the third concept out of that one is health promotion for each age group. Second one is like developmental psychosocial kind of tasks. And the last one was health promotion. So if you were planning teaching, or you were teaching a client from a certain age group, or you were assessing their health promotion needs, what kind of things are you looking at in each age group? Is that it for me for a minute? I think so. I think that brings us, oh no, older adult. Hold on, let me see what else. No, because it's pretty much covered in what I told you about growth and development. Just carry that out to the older adult age group too. And that brings up culture and spirituality.
I'm looking for just a few minutes. Okay. The kinds of things that we might see that would be indicative of, I'm really looking at chapter, I think 19, or is it 18? A little bit of both, I guess. Your spirituality, and, you know, there's difference between religion and spirituality. I guess religion being more of an organized thing, and spirituality has to do with our beliefs, and they're not far apart. You do need to, and one of the things, a lot of you I know work in hospitals. I know that a lot of you have seen hospital employees, maybe a nursing assistant who is bilingual, serve as an interpreter. She might not be a formal interpreter, or she might actually be included on the list of interpreters for that hospital. If even a family member, and we used to do this a lot in Enid because of our Marshallese population, and there still are not very many Marshallese healthcare workers, but we would let family members serve as interpreters. But Enid, is it okay to do that? No, it is not. And you still see it done because it's the fastest, easiest, most convenient thing to do. But because I don't speak Marshallese, how do I know that that family member is actually conveying what I want them to? And how do I know they're not putting in their wishes and wants? So, we need someone who's kind of removed emotionally from the situation. We need professional interpreters, and most of the hospitals have gone to those phone systems or computer-based systems that have, 100 or more languages in them. And that way, that the interpreter service is not biased in any way. And because we're not even conscious of our own biases. And that includes hospital employees. I don't know what I was thinking. I let one of my students serve as an interpreter last year for a surgeon, and he came to find her every time he saw her on the floor. Maybe that was the year before. Anyway, I should not have let her do that probably, because I don't know that she had any biases. She really didn't know the client, but it could have turned into some sort of awkward situation. So I probably should have said, I'm sorry, Dr. Cole, but you gotta use the phone. You gotta use the system that's in place here. I know that it takes 5 minutes longer, but that's the way it goes. So we really do need to follow the rules. Spiritual distress. Just be attentive to your clients and look and do a little reading, see what kind of things might be spiritual distress. What we're looking for is for someone to have a peaceful, dignified death. So if you ask yourself, okay, this person is terminally ill, they're gonna die shortly, and that might mean 2 days, 2 weeks, 2 months, but are they, do they seem to, and if they don't, then what seems to be missing? What am I picking out that's telling me they're not? And is there anything that I need to do as a nurse, or get someone else in here? I'm not a spiritual expert, I'm not a religion expert, but I can offer, whatever resources are available in the community, or, if this person's lonely, I can ask them if I can call family. If this person, needs more, they're wanting their family to spend the night, the family wants to, we've got a room with a couch over here, we can move them into that room. There's little things you can do to make their dying process a little more peaceful. And of course, we always look to maintain dignity as long as we can. Also, as far as culturally responsive nursing care, we talked about the different types of things, maybe that people might want the hot or the cold foods. Maybe they don't want to eat the hospital food, but might do better if they're bringing in their own. And with that situation, it's like, I don't want them, this person's mother to feel like she has to go home and cook for them. I always feel kind of bad about that. But if that's, most of the time, that's what their choices are, because they just don't eat. Typically, a lot of people just do not eat the food that's served in the hospital. And it's perfectly fine for them to choose to bring in their own food. Now, if you just happen to glance at it and say, gosh, there's just not any protein there, that's basically vegetables, with not vegetables, not anything that looks like it's got much protein in it. You might get a little help from the dietitian, or you might ask them, do you eat nuts, do you eat meats? Try to find out ways to, increase. Would you drink a protein shake if we brought it to you in addition to your food from home? If they need protein to heal, you might try to find ways to work with that. But basically, we're not going to try to change someone's diet. If someone is a strict vegetarian, and you're not going to insist that they eat you know, Ross State while they're in the hospital, because they're just not gonna eat at all. We're not trying to change people's lives or cultures, we're just trying to work with them. One of the things that it didn't really talk a lot about in the book, with our, Native American population is the sweat lodges. And I'll ask you first, what do you think the purpose of a sweat lodge might be? What would it mean to a tribe member, necessarily, if they wanted to use a sweat lodge? Just a west.
To get rid of the, yeah.
Cleansing, to have a vision, okay? It can be a spiritual need, and it can also be a physical cleansing, which you guys did really good. If they feel like there are toxins in their body, some of the tribes, I think, the Plains Indians, the Cheyenne and the Arapaho, Lakota, I did a little research yesterday, and a lot of it said, you know, there's different reasons. Some of it is for spiritual purposes, and some of it is to rid the body of toxins if they've been sick. So if they feel ill, if somebody's ill, the, you know, the medicine man or woman for that tribe may prescribe a sweat lodge, to help remove whatever they believe is causing the illness. So, we didn't really talk about that earlier. That's really, like I said, that's another short chapter. Spirituality, we are just not like I said, we're not the experts. It has a little about herbals, but I don't think we need to be, you know, some of the most common ones, I think we already know that are, tend to be low back for the blood pressure and things like that. So there is on page 299, a practice guideline there, but I don't think that there's anything that you need to hone in on particularly there. Praying with clients. The book talks about whether it's appropriate for nurses to pray with the patients or not. Generally, it says that we should not kind of put burdens on other people, but we should be agreeable to, if we're comfortable and they're comfortable. You know, if they ask you to join, and they ask you to pray for them, and you're comfortable doing that, then that's okay. But it's really about them, not about us. And we're there as a healthcare professional, not as a priest or a reverend or anything like that. So get the experts involved if you find yourself someone who really needs quite a bit of assistance, then call somebody in. That's about it on that subject. What's next? That was like elimination. Okay, that was mine too. And Ms. Hayes said she had just kind of a general statement she noticed that, and I had one, and I was looking over a few old tests with a few students to see kind of what kinds of questions they missed typically. And I've done that a few times through the semester for the last few years, just to see if there were patterns, like if this person consistently misses pharmacology questions, for example, or this person has certain tendencies with select all that apply. They have this rule in their head that it's got to be 3 answers. And even if they don't like 3 answers, they can put 3 answers anyway. So those are a couple of things. But one thing that I've noticed, and I still see this, and it has a little bit to do with the nursing process, and I think it's where we have common sense or we have experience of some level, and we recognize that there's something wrong with this client and there's something we could do to help. So we kind of skip through and go into nursing actions before we really have, we have enough of an assessment of the client. And in the influx world, you don't do that. You need enough assessment, and I see people miss questions, of a large variety of people jump to doing actions when they needed to do a little bit more assessment. So, maybe just ask yourself, if you're having trouble with a question, well, do I have enough assessment information? Because this answer is assessment, this answer is action, and if I don't have enough assessment to go to action. Just a way of checking yourself. And that doesn't have to do with eliminations, but it was just a note that I had made to myself of something I had seen, students have problems with. So, elimination. So one of the, the nationwide efforts that is going on to reduce infections in hospitals, has to do with indwelling catheters, right? We have, CAUTI. What does CAUTI stand for?
Catheter.
Okay, catheter-associated urinary tract infections. So the Joint Commission, the Centers for Medicare and Medicaid, everybody cares about quality in the hospital. People who grade hospitals, they look at how many catheter-associated urinary tract infections you have, because a lot of those are unnecessary. So what is something, Stillwater, that you can do as a nurse to reduce the number of urinary tract infections?
Remove it as soon as possible.
Absolutely. Every day you're taking care of that patient, you ask yourself, how long has this catheter been in, and is it still needed? And you serve as a reminder to the physician often. They're supposed to be doing that too, but they've got a lot of other things on their mind. If you're taking care of 6 patients today, they might be taking care of, 6 in the hospital and 50 in the office. So they may forget. So it's good to always remind them. They might even forget the person still has a catheter. When you just mention it, they're like, oh gosh, I thought we took that out 2 days ago. So that is a very good answer. Another thing, Tom Boyle, what's another thing you can do that would reduce the amount of infections in people with indwelling catheters?
Don't place them if absolutely necessary.
Okay. Don't put them in the first place. A couple of the other things is, of course, good hand hygiene.